Today we will discuss about IVF stimulation and other protocols. There are a lot of confusion about the ideal protocol in different group of the patients. If I speak broadly, commonly used protocols are long standard agonist protocol and short antagonist protocol. Both the protocols with little modification works well in all group of patients. There are certain inherent advantages and disadvantages of all protocols. So that is why we have to modify in the terms of dose or some additives or maybe in the mode of trigger in particular group of the patients. If we want to understand the stimulation of the IVF and the protocol, there are certain basic theories, endocrine theories, which we need to understand. One of those are two cells, two gonadotropin theory. The antral and pre-antral follicles. The LH receptors present only on theca cells and FSH receptors only on granulosa cells. So in antral and pre-antral follicle, the FSH, they have only FSH receptor. The initially LH role is minimum in folliculogenesis. In response to LH, the theca cell start producing androgens from the cholesterol and diffuse this androgen into a granulosa cells, where under the effect of FSH, which induces aromatization and which converts androgens into estrogen. So this is two cells, two gonadotropin theory. Another theory which we must understand is FSH threshold. In the pools of antral follicles, they have different sensitivity to FSH depending on the receptor densities. Each follicle have threshold of FSH level selectively beyond which they keep growing. Those having lower threshold, they becomes first to grow by mitotic activity and starts secreting estrogen. This threshold window is open till mid-follicular phase in natural cycle. The threshold window gets expanded with the hyperstimulation, so better to avoid FSH in late follicular phase to stop recruitment of the new follicle. What is FSH window? The follicular growth is maintained till FSH level remain above the threshold. That follicle will keep growing. Is there any requirement of LH? There are controversial views, but there is a more trend and more studies are coming up which are saying the LH, although in less quantity, is required right from the initial phase of the stimulation, but which is required definitely after mid follicular phase. If you look at the literature, the 1% of the LH receptors required to be occupied for steroidogenesis, which is normally sufficient even after long down regulation. If you measure serum LH level initially, and if it is less than 1 international unit per liter, it is insufficient. This patient requires definitely LH activity right from the beginning. So HMG would be an ideal gonadotropin to start with. The LH threshold under which the steroidogenesis and folliculogenesis affected cannot be assessed by standard plasma LH concentration because of the variation in the bioactivity and bioavailability. Surprisingly, the one study says that when LH was less, E2 oocytes and number of the embryos affected, but the blast development was not affected. Now let us discuss about LH ceiling theory. There is something called LH window. Role of LH is very critical. The level should be neither too less nor too high. If the LH level is maintained within the window, there is normal follicular growth and development. There is normal paracrine signaling activated by FSH and LH. There is adequate granulosa proliferation and functional maturation. There is normal androgen and estrogen biosynthesis, and there is full follicular and oocyte maturation. Suppose LH level is too less than 1 international unit at the initiation of the cycle. Then follicular growth will definitely occur under the action of FSH, that is granulosa cell proliferation, because as we have seen in two gonadotropin theory, the small follicle granulosa cell have FSH receptors, though FSH can easily activate granulosa cell proliferation. Even aromatase activity can be induced by FSH. There will be induction of granulosa cell aromatase activity, but there won't be any paracrine signaling between granulosa and theca cell. So there will not be any androgen synthesis. So the substrate for estrogen synthesis is absent. So there is estrogen synthesis will be greatly affected. So there won't be any full oocyte maturation. Now suppose LH level is too high, then there will be a follicular atresia of non-dominant follicle because they do not have LH receptor. LH receptors are acquired once the follicle achieves 10 millimeter, 8 to 10 millimeter size. So premature luteinization can occur in pre-ovulatory follicle, and overall the oocyte development will be compromised. Very recently, a theory called sweet point has come up. which clearly concludes the necessity of LH activity across all spectrum of the patients, across all stimulation protocol, the need of LH activity right from the beginning of the cycle. Why it is so? The FSH only stimulates stimulation increases the granulosa cells progesterone production. If LH is added, it helps in conversion to androgen precursors, and by that it helps in forming estrogen. But suppose LH is not added or LH is insufficient, there will be increased progesterone production in the follicle, which deranges the quality of the oocytes. To prevent progesterone elevation, the sweet point theory recommends the ratio of LH to FSH to keep between 0.3 to 0.6. This is called sweet point, and this holds true for all spectrum of the patients and all protocols. In the initial phase of the cycle, better to keep ratio at 0.3, and in the later half of the cycle, better to keep the ratio at 0.6. The extreme deviation further from sweet point were at greater risk of progesterone elevation, and which was more pronounced in lower ratio rather than higher ratio. So, if choice is there, or if there is no option, I would say, then better to keep the ratio higher. So, indirectly, this theory proves the superiority of the HMG, because in HMG it is equal, FSH and LH activity is same. If it is a 75 international unit HMG, it contains 75 units of FSH and 75 units of the LH activity. Now suppose the LH level is too high, how it affects in the folliculogenesis? This exactly happens when basal LH level is high in case of PCOS. High endogenous LH increases the ovarian androgen production. The androgens, because it acts on thicker cells, and thicker cell produces more androgen if the LH activity is more. These androgens are converted into a more potent 5-alpha reduced form of androgen, which cannot be aromatized to estrogen. So there will be a collection of androgens, there will be hyperandrogenic environment in the follicle. This androgen will be released in the circulation. Circulatory hyperandrogeny will be there. Hyperandrogenemia, it inhibits FSH induced LH receptor on granulosa cells, which inhibits progressive follicular development, and it causes atresia. The hyperandrogenemia, it inhibits sex hormone binding globulin production, leading to increased circulatory androgens, which further increases the insulin resistance. So it is a vicious cycle. Androgen decreases the sensitivity to estrogen and progesterone feedback. So there is no correct interpretation about the estrogen and progesterone by pituitary. So maybe erratic secretion from the pituitary. It also causes abnormality in feedback control of the pulsatile GnRH, which resulting increased LH secretion, which further stimulates the ovarian androgen production. Again, it is a vicious cycle. Now, the gonadotropins are used commonly for the stimulation in IVF cycle. There are certain problems which we need to understand about the gonadotropin. The one is cold chain, which is very important, and we must all have observed that there is no company consistently supplies a gonadotropin with the same potency. Probably their manufacturing process is good, but their cold chain maintenance is not good. There is some problem at some level, either at storage level or transportation level. So when you are ordering a gonadotropin for use in IVF, you must make sure, and if it is possible, you try to take delivery from CNF only rather than distributor, dealer, representative chain. Because if the cold chain is broken, if that injection is kept outside for maybe 20 minutes, 30 minutes, 40 minutes, the potency loses. And this is very important, especially oocyte donor patient. The donor are doing their work, donating the oocyte for their monetary gain. So they need to be educated about the maintenance of cold chain, because sometimes they are staying far from the center, so they insist to carry the injection with them, and they take injection by themselves or with some help of some another general practitioner of their residential area. Many times they do not have fridge. They carry the gonadotropin injection in just simple plastic bag. They wait in the queue in the general practitioner's clinic. Then they take the injection. By the time the cold chain is lost, so you do not obtain expected follicular growth. Another problem is a batch to batch consistency. Most of the Indian company, the gonadotropin raw material is acquired from the China, or at the most one or two company from Korea. But most of the time the raw material is from China. There are hardly any company who acquire gonadotropin raw material from Germany consistently. For maybe one batch or two batch or occasional batch, they may produce a certification that they are acquiring raw material from Germany, but which is not for every batch. And you know, China, the raw material quality depends on the price which is offered to them. So you have to make sure that you use the gonadotropin which has got good raw material. So what I do, I initially always order for a small quantity. I use for one patient. If I am satisfied with the response, then and then the same batch I order for larger quantity. So you have to follow that. The disadvantages, but there is no option, of gonadotropins are inconvenience of injection. A lot of practicals are going on. They are trying to manufacture the gonadotropin, which can be taken in the oral form, but still they are not successful. Gonadotropin injections are quite costly, and it is the main expenditure in IVF. If we keep IVF asides in non-IVF cycle, the problem with the gonadotropin are multiple pregnancies and ovarian hyperstimulation syndrome. There are now a lot of debate is going on whether to use recombinant FSH or HMG. The Cochrane data has clearly confirmed the superiority of HMG over recombinant FSH. The recombinant FSH has got certain advantages. It increases the follicles in cohort, so there are increased number of oocytes. As a result, we get more embryos. As a result, we have got more embryos, supernumerary embryos for freezing. And there is no batch variation in the efficacy. These are the two important advantages. So the overall, the cost of recombinant FSH is higher. But at the same time, if you divide the cost per oocyte, it is almost same as HMG. Now let us discuss the advantages of HMG over recombinant FSH. As we discussed, the Cochrane meta-analysis has concluded the superiority of HMG over recombinant FSH. The recombinant FSH causes progesterone elevation more frequently. So many times fresh transfer may not be possible at that time. The LH component of the HMG is very important in stimulation, and chances of PE is less with HMG, because with the help of LH, the progesterone is converted into androgen and into estrogen. The HMG is distinctly superior in stimulation of poor responder and elderly patients. The chances of OHS are less compared to recombinant FSH. The another important point is the cumulative LH activity while giving HMG, because HMG LH activity in the HMG is majority cases derived from SCG, and SCG has got longer half-life. So the cumulative LH activity helps in luteal maintenance, luteal support. Overall, the development of the single dominant follicle without intermediate follicles are higher with the HMG, because the smaller follicle, they do not have LH receptor. So the growth of smaller follicle is hampered and the growth of the larger follicle is increased. Now, if we use indiscriminately HMG in the higher dose than required, because HMG is very economical drug as compared to recombinant, the price is very less. So there are certain problems which are related to indiscriminate use of HMG. The traditional HMG contains balanced mixture of LH and HCG, whereas highly purified HMG contains negligible LH and 9 to 12 units of HCG. In 75 IL, I am talking about. The high dose is associated with the granularity of the perivitallin space of the oocytes. The high concentration of the LH in HMG causes maturation of the oocyte before ovulation trigger. So, a delayed trigger in such case can lead to oocyte aging, as a result causing fragmentation of the polar body, and these are not a good oocyte, so they are less likely to give a pregnancy. So you have to be very precise when you are exclusively using HMG. The trigger should not be delayed. As we discussed earlier, which are the women who are likely to respond better to HMG than recombinant are young diminished ovarian reserve, elderly women, and over down regulated normogonadotropic women. They are more likely to respond better to the HMG than recombinant FSH. Next time we continue discussion on IVF stimulation and protocol only. Thank you very much.